Hello. Um, I think I've tried to record this about 40 times. I'm not even lying, so I apologize, but it will be out today. So the endocrine system. This probably is my least favorite unit to go over, and um, there was some of the things that I want you guys to know about were actually taken out. Um, so I don't know if if you guys want to go over it at what some point. The two disorders are the diabetes insipidus and the syndrome of inappropriate antidiuretic hormone, the SIADH. Um, you guys will see this, and you will have it in third and fourth semester. I kind of wanted to give you guys a crash course in it real quick, but we were told we had to take it out by um, someone else. So if you guys want, I can do just a short video sometime about those two disorders. All right. So I can never get the first slide to work. There we go. So these are all the endocrine glands, organs. Um, if you remember, these are the things that secrete the hormones. These are the things that try to keep everything in regulation. Here's basically what I just said. Um, Hormones, they do a lot of different things. Um, Reproduction obviously is the biggest one that we think of, but it also helps with the circadian rhythms, cardiac muscle, smooth muscle. They help with growth and development. They keep the energy balanced, metabolism. As you'll see once we get into like hypothyroidism and hyperthyroidism, you'll see the energy balance, the metabolism, that type of stuff. So what it's the best way to go about this is to know what the glands do and what happens when they don't work right. Um, so, so you guys have heard that hormones are regulated by the negative feedback process. What this means is if there's a stimulus in the body, say there's a low, I don't know, um, that hormone is going to be secreted in response to if there, like there's something low or there's a stimulus. Um, if you think of it like, well, yesterday when we had our air conditioning on, and it was so warm, and every time the house got warmed up just a little bit, the air conditioner would kick right back in, and it would just keep it at that temp, whatever we wanted. Um, yeah, so they're kind of difficult to understand. So this is just kind of a rough overview, and I don't want to get into all the deep, dark secrets of the endocrine system because honestly, it gets very deep. So I'm just gonna pause this for a second. All right, I'm back. So the biggest thing with endocrine disorders is they're very hard to diagnose. Um, it's not like the symptoms are in your face, life-threatening. It's more, you know, hunt or the humpback. It's more the eyes. It's maybe a slow metabolism. It's maybe a body shape. So it's really hard to diagnose endocrine disorders. Says on here bottom of Maslow's hierarchy. I'm not really sure what that means, so please just scratch that out. Um, with older adults, some of the aging processes actually mimic endocrine disorders, or endocrine disorders mimic aging processes. So you really kind of gotta weigh and see what's aging, what's an endocrine disorder. So primary, remember, I think you guys will get this in health alt. Primary is the endocrine gland or endocrine organ. There's a disorder within that gland. Secondary, there's problems in the body. There's there's other problems in the body that are causing problems in the gland. So it's secondary. Um, Endocrine assessment. Once we get into the disorders, these symptoms will make sense, I promise. So when we're doing our assessment on the endocrine system, we need to think about, ask them if there's been any changes in their growth. Has it sped up, or have you not grown in 2 years? Your metabolism, how has that changed? Have you had any problems with reproduction? Glucose regulation, maybe there's sugar drops now. Or they can just tell you symptoms of like hyperglycemia or hypoglycemia. Health history, we want to know if they've lost any weight, or gained any weight. Like I said, that metabolism, sometimes it speeds up, sometimes it slows down. But we want to ask them if they have unintentionally lost weight or gained weight, if they're always hot or always cold, if their activity tolerance has changed, maybe they're going, or maybe they just can't get anything done. Their heart rate, maybe it's going really, really fast, or maybe it's going really slow. Mood changes, skin, hair, and nails, they can thin out, the hair will fall out, their skin can be dry, and their nails and their hair are brittle. Hold on, I got a little monkey in here. Sorry, she was just stealing my snacks. Um, Change in energy level, maybe they're going, like I said, going. Maybe they can't get anything done. Maybe they do one small thing and they're wiped out for the rest of the day. One big thing, we'll get into it, have their hands or their feet gotten larger? Like maybe last year I wore a size 6. This year I wear a size 10. That's a really big red flag. Um, any swelling noted in the front of the neck, that's goiter. We'll go over those. And what's their family history of thyroid, um, or endocrine? Is there issues with diabetes? Is there thyroid problems? So these will all make sense once we go over some of the disorders. So common diagnostic tests, I really don't um, know what these slides are. I apologize. But common tests for endocrine, apparently there's stimulation tests and suppression tests. I don't want you guys to get caught up on this, but sometimes we need to stimulate the gland, or maybe we need to suppress the gland. It just kind of depends what's going on. Maybe they're hyperthyroid. They're going to try and slow it down. The hormone tests, there's lots and lots of hormone tests. T3, T4, TSH. Yeah, that's just to name a couple of the thyroid ones. The best way to learn your labs is, I'm pretty sure I showed you this the last lecture, but lab tests online. So if we want to type in thyroid, do thyroid panel. And there's the test that we were looking at: TSH, free T4, free T3, or total T3. So just keep this in your back pocket. All right. The hypothalamus and the pituitary glands are obviously in the brain. This is probably the master or the main gland for the endocrine system. These two are. So the hypothalamus, you can see, is just a tiny, very small area right in the center of the brain. Um, it's in charge of the autonomic nervous system, um, and how the pituitary gland works. So it controls body temperature, controls thirst, hunger, and trying to keep all these systems in homeostasis. Um, the autonomic nervous system, remember, this is what controls all the automatic things. That's how I think of autonomic, automatic. So heart rate, body temperature. As you guys, I don't know if I've talked to you guys much about my daughter, but she has a disorder of her autonomic nervous system, and she can't, her heart rate is generally really, really high. Her temperature, she's usually very, very warm. She's always thirsty. Um, so just think that the hypothalamus controls all the automatic functions of the body. Pituitary um, is is another master gland, I guess. Um, there's an anterior portion, there's a posterior portion. The anterior secretes things like the growth hormone or the TSH or the ACTH or the FSH, prolactin, and the melanocyte stimulating hormone. We will get it. I'm not expecting you guys to know the labs right quite yet. I do want you guys to kind of start putting together things like the TSH is for the thyroid. It's the thyroid stimulating hormone. The FSH, follicle stimulating hormone. LH is a luteinizing hormone. Prolactin. This is a hormone used for breastfeeding. Hold on, my dog came. I told you my house is crazy. I apologize. Alright, sorry about that. I'm back. My daughter babysits for Holly. You guys probably had her in first semester, Holly Wolf, and so she had to come and chat with me before she left to go up to Holly's. Alright, so the posterior part of the pituitary releases ADH and oxytocin. I just kind of want you guys to have an idea what the pituitary gland does and which hormone it secretes. Alright. Alright, so this is where I'm skipping all of the stuff I wanted to talk to you guys about, a couple disorders. If you have the old PowerPoint with the red slides, cut up to slide 25. So growth hormone deficiency, this is the part that or the hormone that's secreted by the anterior pituitary. When there is an issue with hypofunction or deficiency of the growth hormone, you're going to have dwarfism. Because growth hormone stimulates bone and tissue, all of that is kind of shrunken down, and it never actually grows into the I don't know what the word I want to use is. I have to close the door so the dog's all right. You can get synthetic growth hormones and kind of help boost, just depending on how deficient the body is. Big thing with growth hormone is it's secreted during the REM sleep. So maybe this is why I am so short. If the person is not sleeping and is not getting that good REM sleep, they can actually have a growth hormone deficiency. Oh, anyways, what do I want to say? So symptoms of growth hormone deficiency. Kids, they're going to be shorter, 3 to 4 feet. Normal body proportions. May have issues with mental disabilities, and may mature sexually later. Adults, you're going to see weakness, sexual dysfunction, headache, mentation changes. They're going to have excessive body fat, decreased muscle and bone mass, high cholesterol. Um, Apparently, it does not affect height in adults. Um, Growth hormone also not only takes care of bone and tissue growth, but it helps with calcium retention, muscle mass and protein synthesis. It helps with the pancreas. It stimulates the growth of the body organs except for the brain, um, the liver, glucose, and it stimulates the immune system. So it does a lot more than just making sure people are growing. So growth hormone excess, like hyper, um, is gigantism. So when the growth hormone is secreted in excess before the growth plates close, um, then that's when this gigantism occurs. There's different ways to treat it. There's surgery, there's radiation, or Parladel. Parladel is actually a Parkinson's drug. But that will slow the growth hormone production and kind of help try and curb that gigantism. Sometimes it can cause, if it's not occurring when the patient's a child and it starts when they're an adult, it's called acromegaly. So the bones and the connective tissue, because growth hormone affects bones and tissue, they actually enlarge. So remember when I said for an endocrine assessment, you're going to ask them if they have had any issues, if maybe they were a size 6 and now they wear a size 10 shoe. This is what happens when you get an adult. A lot of times shoe size is a big red flag, hat size, ring size, hands, and their hands and the feet get bigger. Pam has it right when she says, imagine Lurch in the Addams Family, because this person goes from being their average size into having big hands, big feet, big bones, maybe big nose, big head. And it happens not overnight, but rather quickly. Growth hormone depletion, again, I don't know why this one came back. I should have organized it better. Back to dwarfism. When a person, their growth hormone is not secreted as much as it should be, when they're in utero, or maybe when they're a young child, they can be, their growth will be limited. Can be caused from damage to the pituitary gland, can be familial, just kind of depends. The head and the extremities are going to be disproportionate to the torso. They're going to be short. The legs will be bowed, and they'll reach puberty later. Here's a picture of acromegaly. Generally, a tumor on the pituitary gland is what causes it. All right, pituitary tumors. Generally, these are benign, but they can wreak havoc on the body by all those hormones going crazy. The biggest, most serious symptom of a pituitary tumor is increased intracranial pressure. They're going to have a lot of vision changes. They might have, I can't say that word, hypophyseectomy. Sounds like a vasectomy to me. Or radiation to get rid of that tumor if it's, bothering them. The procedure is just basically the incision under the upper lip, like they lift up the lip, go under there, and go through basically the sphenoid sinus. After surgery, they're going to need to have their airway monitored very, very closely because they're going in through their airway to get to the pituitary gland. Hormones are going to have to be replaced. We're going to have to monitor for DI, which is diabetes insipidus, which is the one of the disorders that we were told to take out. Diabetes insipidus is basically the body doesn't hold on to water and they can actually urinate very dilute urine up to 15 liters a day. So it has nothing to do with diabetes. It's called diabetes insipidus, and they urinate all of their fluids out. We're going to want to watch them for neural changes because they're in there digging in the brain. And so we're going to do our neuro checks. Going to check the dressing for any cerebrospinal fluid, and that actually presents as a ring. It's the only body fluid that really does it, and I have never seen it, but I've never worked in a place that dealt with, I've never worked in neuro, so, but it will cause a ring on the old dressing. And they're going to be monitoring the urine-specific gravity because of the diabetes insipidus, just because the urine is so diluted that I think it's like 1.005 and below is average for diabetes insipidus. All right. Thyroid gland. This is the one you will see. Everybody and their brother has thyroid problems. I apologize, but I had to pause again. I apologize. I have a class at 11, so I have to keep watching the time. All right. So like I said, thyroid is the most common issue when it comes to endocrine, that and diabetes. In hypothyroidism, you're going to see the TSH, the T4, the T3, those levels are going to be decreased. You're going to see them low. The thyroid gland is not producing enough thyroid hormone. TSH is actually secreted by the pituitary glands. Oh, I just said that wrong. The T4 and T3 levels will be decreased. The thyroid gland does not produce enough thyroid hormone, so the pituitary secretes more TSH. So if the TSH is high, it's a primary issue. So basically saying the thyroid is the problem. If the TSH is low, it has to do with the pituitary or the hypothalamus not secreting enough TSH, if that makes sense. Sometimes the symptoms of hypothyroidism are a huge mistake for being diagnosed as the aging process, like I talked about when we were going through earlier. I don't know that I don't know if I agree that it's most common 30-60-year-old females, but you'll see it quite a bit. So when you think about hypothyroidism, think everything slows way down. Their metabolism is slow. They're always cold, so their heat production is slow. Neural, their thinking is slow. Their respirations will be slow. Their GI is slowed down, so they're going to be constipated. Musculoskeletal, their reproductive, cardiovascular. Their heart rate is going to be slow. They're going to be losing hair. Their nails and their hair are going to be brittle. Their skin's going to be dry. That heart isn't going to have the strength that it needs to pump correctly, so they're going to have heart failure. So when you think hypothyroidism, think slow, think low. Everything slows down. Generally, hypothyroidism is caused by a congenital defect. Sometimes it can be caused by inflammation of the thyroid or even an iodine deficiency. There is a thing called Hashimoto's thyroiditis. This is an actual autoimmune disorder that actually destroys that thyroid tissue. When we talk about iodine deficiency, back in, I think it was the 50s. I'm trying to think how old my mom is. So it's like 50s, early 60s. I think so, maybe towards the end of the 60s, maybe in the 70s. I'm not exactly sure when they made the change, but we have iodized table salt. And this is why, because back in the time my mom's like 70, I think 72, but back when my mom was in grade school, every, I don't know, I think it was week or every month, they would come in with their goiter pills, and they were flavored like chocolate. So the kids really liked them. But it had iron or iodine in them to prevent um, th all the issues with the thyroid. Um, so a little bit later, they actually tried to figure out something that every family used, and they came up with salt. So they put iodine in table salt, and that's why we have iodized table salt now. Um, so this goiter, and that's why they're called goiter pills, because that thyroid actually, when it's deficient and it's not working, it'll get bigger, to produce more hormones to work better. So it's trying to get to work better as a bigger organ. Um, and these were quite common before the goiter pills, before the iodized table salt. I actually have a friend right now that has one, and I mean, it's not terribly noticeable, but it is there. Um, Hypothyroidism can also be secondary. There might be a lesion on the pituitary or the hypothalamus. Um, yeah. Issues with hypothyroidism is they can actually go into what's called a mixed edema coma, um, where they've been so low because of their thyroid isn't working. Um, like I said, all of the symptoms of hypothyroidism, their metabolism is going to decrease. I'm not talking just food, I'm talking everything. Level of consciousness is going to decrease. Cardiac output is going to decrease, which means their kidneys are going to shut down. They're going to have respiratory failure, which can actually lead to death. Um, these people really, 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 really need Synthroid, by the bucket load. Um, so for hypothyroidism in general, not just the mixed edema coma, the treatment is Synthroid, which is levothyroxine. Same brand, same time of day, so that they're getting the hormone. Um, these are the pills that we give at 6 o'clock in the morning rather than 8. A lot of times it doesn't happen in the nursing home, but basically, if your person takes it at 8 normally, then you just stick with it. If they take it at 6 on an empty stomach, which is what is recommended, then you stick with that. Hyperthyroidism, there's too much thyroid hormone. T3 and T4 are going to be up. TSH is going to be low. It could actually really cause thyrotoxicosis, which is where I can't talk today. Um, their metabolism is way up. Um, the flight or fight response is going to be going haywire. That feeling you get when you're like, oh, I gotta go or I gotta fight. Um, that's what they feel all the time. So, um, generally, hyperthyroidism is what's called Graves' disease. Um, it's an autoimmune disorder, and the exophthalmos is like the buggy eyes. That's what they are, is the buggy eyes. So when you think of hyperthyroidism, think fast. Everything speeds up. Their heart rate, their metabolism, their catecholamines, um, their weight loss because their metabolism is so high. They're going to be really, really warm, so they're not going to be able to tolerate heat. They're going to be shaking and tremoring, and they're going to have heart failure. Yeah. Can actually be a thyroid storm or a thyrotoxic crisis. This is very, very hyperthyroidism. I know my brother called me, I don't know, it was probably 6 months ago, and a friend of his thyroid levels were through the roof, and he calls me, he's like, "Hey Lise, what's a thyroid storm?" I was like, "Please tell me you're not going through one because you need to be in the hospital right now." "No, my friend is." I was like, "Oh, okay, well he needs his thyroid taken out." Um, and yeah, it was military, so he didn't get in for, I think it was 3 weeks that he wasn't going in for surgery. He made it, but it was very, very, very nerve-wracking. Um, Symptoms of thyroid storm: metabolism is going to spike way, way up, high fever, tachycardia, high blood pressure. They're going to be restless, and um, they might actually go into delirium, coma, seizures. It could get that bad. So the first thing we need to do is take care of the life-threatening issues first. And then um, anti-thyroid meds. We're going to get the patient cooled down because they're going to be very, very warm. Tylenol, wash rags, cooling blanket. Heart and respiratory are going to be our biggest places or biggest symptoms to watch. Beta blockers for the heart rate. Glucocorticoids, IV fluids. IV fluids will help cool down as well. But it's a big, 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 scary deal. So here is the top one is the bulging eyes or bug eyes. And then you see on the bottom one where pink is like a normal size thyroid and the blue is the enlarged thyroid. So you can see where it kind of leaves a little lump in the neck. Hyperthyroidism, like I said, T3 and T4 is elevated. TSH might actually be low. Could be a thyroid ablation that they have to do, might actually take the thyroid all the way out. Propranolol, because propranolol and which is a beta blocker, will help get that heart rate down. And they might need radioactive iodine to destroy part of that thyroid gland because it's so big. Because remember, when they're not working right, they grow bigger to try and work better. And after the thyroid's ablated, taken out, destroyed, whatever, these people are going to probably be, or are usually going to be on Synthroid, so that they can have normal thyroid function, basically, after their treatment. Oh, gosh, my head is not happy. What am I missing? Alright, I'm going to go through a couple more slides and then I'm going to take a break and do my other class and then I'll come back and finish this. So radioactive iodine is generally an oral that they take, one dose. If it's really, really high, these people are going to be in the hospital. People that are pregnant should stay away. Anything that's radioactive, obviously. Body fluids are contaminated with radiation, so generally it's like wear double glove, flush twice, you name it. And if the patient's at home, maybe it's not a real extremely high dose, but they need to be avoiding close contact with their family for a week, just because of the radiation. All right, goiter. You can see this. Again, there's a normal thyroid gland, and then there's an enlarged thyroid gland causing the lump, the goiter. The TSH levels are going to increase, so that thyroid's going to increase in size to try and work better. Sometimes that thyroid will grow so big that it'll affect the trachea, so there's issues with swallowing and breathing. I think I've kind of covered everything. Add iodized salt, Synthroid, um, if the TSH levels are low. Then there's a nursing diagnosis. All right, so I'm going to stop here so I can. Oh, I got time. I got a little bit. A couple more slides. All right, parathyroid glands. There's 4 to 6 glands on the thyroid, on the back of it, and they secrete the parathyroid hormone, which is the antagonist to calcitonin. If you remember, calcitonin helps with calcium absorption. There we go. I couldn't think of the word. And phosphates. So this helps with all, because remember, calcium helps with like muscle tone and cardiac issues and blood clotting, and I mean it just does a lot. It helps with our bones. Hyperparathyroidism, there's going to be overactivity. The PTH, the parathyroid hormone, is going to be increased. Calcium levels are going to be increased because it's causing the more of the calcium to come out into the blood. Oh, I saw that after I said that. More is going to be absorbed in the small intestine and reabsorbed in the kidneys, which is going to be hypercalcemia. Might be a tumor in the parathyroid gland, or chronic renal failure can actually cause hyperparathyroidism as well. We might see fractures that have no real reasoning behind. Kidney stones, osteoporosis because the bone's breaking down, kidney stones because of all the calcium, pathological fractures because the bones are breaking down, like with osteoporosis. We're going to see hypercalcemia. We're going to see hypertension. We're going to see lots of GI issues. The symptoms we're going to see for hyperparathyroidism are all related to the hypercalcemia. So treatment for it, basically, we need to tell them to slow down on all their calcium. We need to have them drink fluids like water, get their activity up because that'll help with their bones and not break them down. Calcitonin to try and keep that calcium to stay in the bones. Sometimes they're going to give Lasix just so we can get those kidneys to get rid of that extra calcium. Oh, I've been talking too much. All right. Hypoparathyroidism, we're going to see a decrease in the parathyroid hormone, a decrease in bone resorption, so hypocalcemia, decrease in calcium absorption in the GI tract and in the kidneys. The calcium is going to stay in the bones. It's not going to go in the blood, so we're going to see hypocalcemia. Generally, the most common time we see hypoparathyroidism is when somebody goes in for like a thyroidectomy and the parathyroids are taken out. Or it can be nutritional deficiencies, so like not taking in enough calcium. What we're going to see is tetany and cardiac dysrhythmias because the calcium really, really helps with the cardiac function, and when it goes low is when we're going to see those dysrhythmias. So other things we're going to see is neuromuscular irritability, tetany, numbness, tingling of fingers, muscle spasms, twitching. There's a test called Chvostek's sign, and if you tap their facial nerve, you're going to see a facial spasm, or Trousseau's sign, which is use a blood pressure cuff, and there'll be a spasm of the thumb and the finger. And this is what we do when we're looking for tetany. What we're going to do, we're going to give them maybe IV calcium gluconate. We're going to get them vitamin D. We're going to give them calcium supplements, phosphate binders, because we want to get the phosphorus taken care of too. Yeah. it can be life-threatening to be hypoparathyroid. All right, now I think I'm going to stop and go to class and get something to drink, actually, because I sound like a frog again. Hello, so I'm back. It has been one busy day. All right. Um, so we'll start back in with the pancreas. The pancreas is both an endocrine gland and an exocrine gland. There's different cells that make up the pancreas. In the endocrine portion or function of the pancreas, there's alpha cells, beta cells, and delta cells. The alpha cells produce glucagon. The beta cells produce insulin. And the delta cells secrete the somatostatin, which actually kind of balances the secretion and the production of insulin and glucagon. So alpha's glucagon, beta's insulin, and the delta cells balance everything out. So insulin, which is produced by the beta cells, actually helps the glucose go to where we need it to. It helps it get transport into the cells, and then so the body's using that glucose for energy production, because we want the body to use the sugars for their energy rather than the proteins and the fats. Insulin, whether it's made by the body or the actual injection, it causes cell membranes to be more permeable to glucose. So once the glucose gets inside that cell, it's actually able to get broken down to release the energy that the body needs for functioning, basically. So the beta cells actually secrete insulin when the blood sugar levels are elevated. And the glucagon is the exact opposite. So when sugars are low, it's going to secrete the glucagon to get the sugar back up there. When there's too much glucose, that insulin will convert that glucose to glycogen in the liver and in the muscles so that it's stored so that it can be used for later. When a body is in a hyperglycemic state is when the secretions, like I said, the hyperglycemia actually causes the body to secrete all of the insulin. Sorry, I'm trying to do too many things at once. There is a note on the notes part of this that I did want to touch on. We have to be careful with insulin just because insulin is actually used not only for hyperglycemia, but it's also used for hyperkalemia with a high potassium level. So when somebody's got an elevated potassium level, they actually might be given insulin. So if they're given insulin for the high potassium, they're also probably given glucose just to make sure that they don't drop too low, because if they're not a diabetic, their sugar might be 100. You give them insulin, they're going to drop, but they'll be given the glucose as well to keep that sugar up. But it actually helps the glucose move into the cell, and when the glucose moves into the cell, it brings the potassium with it. So it is used for high potassium levels. Generally, it is given with like albuterol too, because albuterol helps with potassium. Weird little things that you learn along the way. The glucagon from the alpha cells are, like I said, it's the sugar that the body needs to make energy. So glucagon actually stimulates the conversion of the glycogen to glucose in the liver, which produces the energy that we need, so that the body's using the sugar for the energy. All of this occurs when a body is hypoglycemic. So when a body is hyperglycemic, it the body's told to release the insulin. When the body is hypoglycemic, they're going to release the glucagon. If you've ever, some of you guys have worked in nursing homes, but most diabetics have a standing order for glucagon. This is just an injection, especially when they can't take anything orally. If their sugar is way, way low, they're going to be given a shot of glucagon. I had a lady once who went to an appointment, and her sugar when she got back was 23. You better believe we were slamming the glucagon in her as fast as we could. All right, moving on. Diabetes mellitus. There are two types. There's type 1 and there's type 2. Type 1 is basically an autoimmune disorder. Hold on, I got too much going on in my house. Hello. So I apologize for all the interruptions. My house is insane, and that's why I record in the middle of the night, because I don't have all these distractions. My aunt kept coming over to my mom's house. I was actually hiding in a bedroom, and she kept being very loud, and I couldn't even concentrate. So, diabetes mellitus. There's type 1 and there's type 2. Type 1 is an autoimmune disorder, and it destroys the beta cells. So if we go back, remember the beta cells are the ones that secrete or produce the insulin. So type 1 destroys those beta cells, so the insulin is no longer produced by the body. Type 2 is from insulin resistance and insulin insufficiency or deficiency. These are most of the cases of diabetes mellitus. Develops over time. 9 times out of 10, or even 10 times out of 10, this is caused by sedentary lifestyle. It has to do with where the weight is distributed around the body. In type 2 diabetes, this is going to be like that spare tire. It's all around their belly. Dietary choices will affect and cause type 2 diabetes. Diagnostics are fasting blood sugars over 126. So, also, the hemoglobin A1C is one that will tell what the blood sugar has been an average for the last 3 months. Generally, we want this between 5 and 6. If it's anywhere above 6, generally that's a really good indicator for diabetes. So our priority with these patients, we need to make sure that they know what caused their diabetes, their sedentary lifestyle. So we need to teach them things that help prevent long-term complications, because diabetes isn't something that you see hyper and hypoglycemic symptoms. It affects every organ in the body. So we need to teach them what they can do to help prevent those long-term complications. So type 1, just to go over this again, the body's not making insulin. It's affecting the beta cells. It's a rapid onset. Generally, this is when you're going to see onset in the younger ages. Juvenile, but it's going to be, they're going to be diagnosed with diabetes when they're younger. Risk factors, I told you the autoimmune response where it destroys the beta cells. Hereditary, might be caused by a virus. Generally, these are the people that have a lean body type. Yeah. when the blood sugars, I don't know, high WBG, I'm not exactly even sure what that is. But type 1 is more at risk for something called ketoacidosis. Treatment for these guys: diet, exercise, and they're insulin dependent. Diabetes in type 1 is a huge, 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 huge cause for chronic renal failure. So, type 2, body makes the insulin, but the cells can't use it. Onset is going to be slow. It's going to take quite a while to develop. Generally, the people are older when this starts, when they're diagnosed. Risk factors: that's hereditary, or obesity. Body type with these guys, like I told you, it's the spare tire around the belly. They're obese. Sedentary lifestyle, poor diet. Talks about the ketoacidosis for this as well. Treatment: diet, exercise. These are the people that are going to be on oral diabetic meds, oral hypoglycemics, or insulin to make sure that those sugars are well controlled. Complications in diabetes, there are so many. Obvious ones: hypoglycemia, that's when the blood sugar is like less than 50. Hyperglycemia is, BGL is blood glucose level. 126 to 250 and above. Anytime the sugar is above 126-ish, we consider it hyperglycemia. Some people can function at 300 or 60 or 50. So we kind of really need to see what their baseline levels are. We're not saying that that's a good place to be functioning, but they can function, and that's maybe where their normal is. So if they're used to having their blood sugar at 300, they may start to have hypoglycemic symptoms earlier, like at 150. So we kind of need to know our diabetics baseline. Type 1 diabetes, diabetic ketoacidosis, that's when these sugars are sky high. The HHNK, the hyperosmolar hyperglycemia, there's going to be macrovascular complications, microvascular complications, and chronic complications. So when you think of diabetes, I want you to think about the sugar molecule. The sugar molecule is very sharp, jagged, and so when the sugars are spilling over into the bloodstream and there's a lot of these sugar molecules floating around in the blood, remember, it's got to go through all the organs. So if these sugar molecules are floating around in the bloodstream, they got to be filtered through the kidneys and, go through the heart and go through the lower extremities. That's going to cause a lot of issues going through all these. So there's chronic renal failure, there's cardiovascular issues, there's a lot of eye issues when it comes to diabetes, circulation issues. A lot of times they don't heal as well. I'm trying to think of some off the top of my head. But just keep that in mind when you're thinking of all the complications. So if you're doing a paper on your nursing home resident or your hospital patient, maybe you're doing, I don't know, NPWs or the concept mapped or whatever you're doing, don't just think in the short term, the hyperglycemia and the hypoglycemia. Look into it deeper and think about what are these chronic conditions that are caused by diabetes, because it is a very huge, huge diagnosis. There's a lot that goes with it. It's not just don't eat any sugar. It has to do with every single organ in the body. Hypoglycemia, They're going to be hungry, they're going to be confused, they're going to be dizzy, they're going to be grumpy, shaky, sweaty, and they're going to have a headache. So generally these symptoms start at 50 and below, but like I said, if the baseline is 300, they might start showing symptoms of hypoglycemia at 150. So make sure you know your symptoms of hypoglycemia. Hyperglycemia, they're going to be thirsty because the body's going to tell them they need to flush their blood, which means they're going to be going to the bathroom more than usual. Their skin's going to be dry. Again, they're going to be hungry. They're going to be sleepy. Their vision might be blurry. Infections or injuries or wounds are going to heal slower than usual. So make sure you review the symptoms of hyper and hypoglycemia. So I have an extra couple slides here. Diabetic ketoacidosis is DKA. This can happen. I just wanted to touch base with these. I know these were a couple of them that were taken out, but I do want you guys to have an idea of this. Can develop quickly or over a few days. This is when those insulin levels are sky high. A lot of times this is when diabetes is diagnosed. These people are coming in not knowing what's wrong with them. They check a blood sugar and they're 600-700. I don't want to get too far into it. You never want to drop the blood sugar fast in DKA because otherwise, with the fluid shifts and the way the fluid moves, they are at huge risk for cerebral edema. They're going to need an insulin drip, which you're going to need to watch their potassium really, really closely. So just know that DKA, and I think they go more in depth in it in I don't know, 1 or 2. But just know that it is out there. It is a very high blood sugar. There's a lot of other issues with it. It is life-threatening. The HHNK, the hyperglycemic hyperosmolar non-ketotic syndrome, is just basically a lack of insulin because of metabolic demands. Maybe the person has a UTI or stress. So just know that that's out there as well. So generally DKA is seen in type 1 diabetes, and this HHNK is seen in type 2. All right, so moving on. Biguanides like metformin or glucophage. Generally, this is what is prescribed first before insulins. Has a huge side effect of digestive upset or diarrhea. I think it's more diarrhea than it is like vomiting. But if we teach our patients to take it with food, generally that helps a little bit with the digestive upset. Sulfonylureas are like glipizide, glyburide, chloropropamide, and tolbutamide. I can't even say some of these. Alpha glucoside inhibitors. I've never even worked with any of these. Precose and Glycet, another causing nausea. Thiazolidine, I can pronounce Actos. This is one that's more used a little bit more, but there are risks for heart problems with these. DPP-4 inhibitors. Januvia is one that we see most often. These are the new insulin types. And then GLP-1 receptor agonists like Byetta and Victoza. These are the newer treatments for diabetes. I do want you guys to review this. Know your rapid insulin, your short-acting, immediate, intermediate, long-acting. I don't know how much 70/30 is used anymore. Um, but it's just basically a short acting and an intermediate acting mixed together. Um, but no like Humalog or Lispro, Novolog or Aspart. Um, those are rapid acting insulins. You cannot give them any more than 15 minutes before mealtime. These are usually given with like long acting, like Lantus insulin. Um, my practice is I want to make sure my patient is eating before I give any of the insulin. So anywhere between 10 to 15 minutes if you are sure your patient is going to eat their meal, or once you know they're eating, give them their rapid acting. Because if, so say they say, yeah, I'm hungry. Okay, I'm going to give you your insulin. And then 10 minutes later their tray comes. Or maybe there was an issue in the kitchen and their tray doesn't come for another hour. Um, they could bottom out really, really quickly. So if you don't want to wait till they start eating, at least wait till their tray is right in front of them. Just kind of my anal thing about it. Short acting is like regular insulin or Novolin is the common ones. These can be given a little bit longer, 20 minutes before mealtime. Intermediate, most common is like NPH. Generally, it's used twice a day, so they'll get it with breakfast and supper. Um, a lot of times they're going to be given like a rapid acting or short acting insulin as well as NPH or Lente. Um, long acting, Levemir and Lantus are probably the two most common. Lantus has really no peak. Onset is an hour-ish, and it covers this person up to 24 hours. So you may see patients getting this twice a day. That's just because that's the way their body needs it. But it can cover the person for 24 hours. A lot of times this will also be given with rapid or short-acting insulin. So no, basically I want you guys to have an idea of what's rapid, short, intermediate, long, and premixed. I want you to know that anything rapid, you need to give less than 15 minutes before they eat. Short acting is like 20 minutes before they eat, and that's regular Novolin. Intermediate might be used a couple times a day. That's NPH or Lente, and Lantus is the long acting. So please make sure you're reviewing your insulin types. Insulin pumps and pens. I don't want to touch on this too much. Insulin pumps are very expensive, but it's a lot better than these guys poking themselves for 3-4 times a day. And sometimes you have two types of insulin, so they might be poking themselves 6, 7, 8 times a day. So a lot of times when I have a friend who's scared of needles, and of course she has type 1 diabetes, so when she was a lot younger, they actually were able to get her a pump. So she um, has the pump and it just takes care of it and she doesn't have to poke herself. Pens are getting a lot more common. So the pens are a lot easier for our patients to use. They just dial the number up and give it. Whereas they used to have to draw it up in an insulin syringe. And if they were elderly or had poor eyesight, they had a really hard time getting the correct dose. So with the pens, always remember that you have to prime the needle. So you put the needle on, dial it to 2, press the button, prime the needle, and then you dial it to their ordered dose, and then you can give it. You have to poke them, sit and hold it in place for 10 seconds after you're done pushing the button, infusing the insulin. Because if you pull it out too soon, the insulin will leak out of the injection hole, and they won't get their full dose. So pens are really, really nice, especially with our elderly patients that would otherwise need to stay in a facility or have somebody administer their insulin. Pump costs about $5,500 and supplies cost about $100 a month. Insulin is very expensive. It's $400 to $500 a month for a vial. I literally cried one day when I was at the pharmacy and I seen a little old lady picking and choosing what insulins to get because she couldn't afford all of them. Um, Insulin pens are also pretty expensive. A lot of times the insurance will cover the insulin pen before they'll cover the vial, but I think there's more insulin in a vial than there is in the pen. Testing strips are not terribly, they're not cheap, I should say. Um, it just depends on what type of monitor our patients have. But if you consider like the most expensive ones, um, like $1.50 a strip, and people are checking their blood sugar 10 times a day because their sugars are um, uncontrolled, that can add up really, really quick. Um, Pills are a lot cheaper than the insulin. Um, but so you can see where this adds up. I have a friend whose daughter was just diagnosed with juvenile diabetes, and the poor kid, I think she was 10, um, was literally poking herself up to 12 times a day. They do have a new, oh gosh, I don't even know what it's called. I'm sorry, it's been a really long day. Um, where they can just apply it to the skin. Called a Dexcom, and it literally has a running total of the blood sugar. And they don't have to poke. She doesn't have to poke her little tiny fingers all the time anymore. It's a wonderful idea. So there are different treatments out there, um, but diabetes is very expensive. Um, there's also actually, oh my gosh, my brain is fried. I apologize. Um, assistance dogs. Another friend of mine that I used to work with actually has a dog that can tell when her blood sugar drops. So when Sarah's blood sugar is low and maybe she doesn't even know it yet, Lucy goes to the fridge, opens the fridge because they keep a towel tied to the handle. Lucy opens up the fridge, grabs the bucket with the juice and the peanut butter and all that in it, and brings it to Sarah. And so Sarah will check her blood sugar, and yeah, Lucy has never been wrong. It's pretty awesome. All right. So, moving on to adrenal gland alterations. Adrenal gland hormones, we need them to sustain life. They keep us in homeostasis. They regulate our whole body functions. Anytime our body is stressed out, they'll do what they can to regulate everything. So, the adrenal glands. From the adrenal cortex, if you remember quart, it's either too full or too low. Mineralocorticoids, glucocorticoids, and sex hormones. From the adrenal medulla is where the stress hormones are secreted from. This is what causes our fight or flight response. Epinephrine and norepinephrine are secreted, and they tell us either to fight or flight. So mineralocorticoids, think salt, mineral salt. It'll help retain salt so that the sodium and the potassium are kind of regulated. Keeps our blood volume, intravascular volume, regulated. Glucocorticoids, think sugar. Sugar. Helps with carbohydrate metabolism, makes glucose, carbohydrates, protein more available, affects their metabolism. Yeah. I told you, it's been a long day. Pheochromocytoma. Generally, this is a benign tumor of the adrenal medulla where the stress hormones are released. It's generally very rare. It's not common. Happens generally between 40 and 50-year-olds. Symptoms, there's a lot of catecholamines produced. So this stimulates the oh my god, sympathetic nervous system. We're going to see blood pressures of 2 to 300 over anything over 150. So if you think that of the normal blood pressure, that is very elevated. There's going to be profuse sweating, headache. Because of the blood pressure is so high, we might see strokes, we might see heart attacks, and this is just because there's so much epi and norepi being secreted that this body is basically in a fight or flight all the time. Diagnosis, catecholamine levels in the blood or the urine, might be a CT scan, might be an MRI. Treatment for pheochromocytoma, remove the tumor and use alpha and beta blocking meds. So we need to get that heart rate and that blood pressure low. Adrenocortical insufficiency. I only have a couple more slides left. Addison's disease. This is hypofunction of the adrenocortical. The gland is actually destroying itself because it's an autoimmune disorder. When symptoms don't really develop until about 90% of that adrenal cortex is destroyed, things you're going to see are really like there's a bronze skin that you'll see. They're going to have muscle and joint pain. Their pulse is going to be weak and irregular. They're going to be low blood pressure, depressed. They're going to be craving salt because their sodium levels are low. And if they eat more salt, obviously, just remember that it's going to up that blood pressure because it's going to hold on to more fluid. Labs, the ACTH levels are going to be elevated. The aldosterone and cortisol levels are going to be decreased. With Addison's disease, a very common side effect is fluid volume deficient. So treatment for Addison's disease is a med called Florinef. It's a mineralocorticoid, steroid. What it does is it helps the body hold on to the fluid. They don't excrete it like they should. It's basically salt, but in a steroid form. But then you also have to watch, if they're on Florinef, you also have to watch for fluid volume excess and edema. These people that have Addison's disease might actually go into what's called an Addisonian crisis, where their levels are very, very low. It's life-threatening. It's an acute insufficiency. Their sodium's going to drop, or blood sugar. Their potassium is going to be high because generally it kind of goes with the sodium. The BUN and the creatinine are going to be elevated with the potassium. Treatment for an Addisonian crisis, if it's not treated, it can be fatal. They need to be rehydrated very quickly. Mineralocorticoids and glucocorticoids, so salt and sugar, need to be replaced. They need to be taken in as much salt as possible. So find anything that they will eat that has salt in it. At this point, it doesn't matter like healthy wise. So like TV dinners, those cheap $1.50 ones, the banquet ones. I think the Salisbury steak has the highest sodium level. The banquet pot pies, beef jerky, anything that has a high sodium content. The Himalayan pink salt has a lot more sodium in it than table salt does. So have them if they will use salt to season their foods, have them use the Himalayan pink salt because they'll get more sodium out of it. They're going to get IV hydrocortisone, but we need to make sure that we're watching their INO and their weight to make sure we're not going more dehydrated and we're not hydrating them too much. And they're going to be on lifelong medication treatments for Addisonian crisis. And then we also need to make sure we're helping them manage their stress, because when their body is stressed out, it can actually throw them into this Addisonian crisis. Adrenocortical excess. You guys might see this more often than the Addison's disease. It's Cushing's syndrome. There's too much cortisol. Most common onset is between the ages of 20 and 50. Things that may cause too much cortisone or cortisol. There might be a tumor on the adrenal gland, tumor on the pituitary gland. They might be on chronic glucocorticoids for another disorder, or even the ACTH is released from like tumors in the pancreas or the lung. Most common symptoms that we are going to see, I want you guys to review these. They're going to have fat deposits in their abdomen. They're going to have a buffalo hump. It's just right up behind their neck. You'll see a little hump, like a fat deposit right there. They're going to have moon face. They're going to have a round face. They're going to have muscle weakness. Their obesity is going to be basically in their trunk. They might have these skinny legs, but they're going to have this big obesity around their belly. They're going to see, you might see diabetes, emotional instability. Their infection rate is going to go through the roof because there's no immune system. Treatment for this: surgery, radiation, and drugs. So this just kind of compares Cushing's to Addison's. So it just kind of compares the sugars. They're basically opposite of each other. One is excess and one is deficiency. So you guys can kind of peek at this. I think we have made it through our lecture. I apologize for all the interruptions, but I honestly have been trying. I promise, I promise, I promise. I do plan on trying to get some things put together for a review, and I would like to do that over the weekend. If you guys have any questions, please contact me. I will definitely be more than happy to help you out with these things. I know the urinary system is pretty hefty. The endocrine, the new one that is posted, I shouldn't say new, it's new to me. It's the one that you guys have. The black and white slides is a lot smaller than what it previously was. So if you guys have questions, please just get a hold of me. All right. Have a good one, guys. I will have this loaded up shortly.